Hello, my name is Karel van Looy. I'm the Global Clinical Application Manager at Breas, and I'm happy that you're all joining this webinar, which is part of our 2021 series. I know that for some of you it's early in the morning, while for others it's already late in the evening, but from wherever you're joining, I want to wish you a very welcome to this webinar. For the ones of you that have attended previous webinars, you know that we will alternate 2 webinars on ventilation with 1 webinar on airway clearance moving forward. And with the exception of this one, all of our webinars are hosted on the last Thursday of the month. Please note that a recording will become available on our educational platform, educationbybreas.com, in about 2 weeks from now. We of course welcome your questions very much, but to organize and optimize the organization of the questions, we would like you to use the Q&A chat function, which you can use or which you can find on the right upper corner of your screen. We will address all of your questions at the end of Dr. Lujan's talk. All that being said, I would like to hand it over to Dr. Lujan from Hospital Partaulí in Sabadell in Spain for his talk on how to read ventilator waveforms. Dr. Lujan, the floor is yours.
Thank you very much, Carl. Good morning, everyone. First of all, I would like to thank Breas for your invitation to present this educational webinar about how to read ventilator waveforms. I'm going to share my screen. Okay.
Yes, we can see it.
Okay, excellent. Thank you, Carl. In my opinion, is not only important the knowledge about how to read ventilator waveforms. It is also important to understand ventilator waveforms. And for that reason, I've included a first part talking about how can we understand ventilator waveforms, and the second part dedicated to the systematic reading of ventilator waveforms. I would like to start introducing the 3 main ventilator waveforms. In red, the pressure time waveform, in blue, the flow time waveform, and in green, the volume time waveform. And one of the main difficulties experienced by the, let's say, rookies is to know where and how should they start the analysis. We have 3 important waveforms, and what's the most important one? The first concept I would like to introduce is that flow and volume, in fact, contains the same information. In other words, at the 2 faces of the same coin. Why? Because volume time is usually obtained by direct integration, that's the same, the area under the curve, of the flow time waveform. As you can see in this picture, the positive part of the flow time waveform correspond to this positive part of the volume time, and the area contained in this curve is the tidal inspiratory volume. The negative part corresponds to the tidal expiratory volume, in which in this part the volume time waveform returns to the baseline. So flow and waveform are equivalent, but it's important to remind that a sort of artifact in the volume time waveform can appear, and you should know this artifact. This artifact happens when the area, positive area below the flow waveform is greater than the negative area corresponding to the same cycle. What happened? If we integrate the positive area, for example, this, and we integrate the negative area and are not well balanced, we can have an artifact like this, in which the volume, without restarting the volume waveform, comes upwards. So to avoid this, manufacturers that present the volume time waveform in their built-in software usually restart the volume waveform when the blue waveform, or the flow waveform, crosses the 0 point from negative to positive, and it's typically this morphology when positive and negative area are not well balanced. In fact, this is an example from the Breas built-in software. The cycles labeled with an asterisk present the semiology. Positive area is greater than negative area with restart. What does it mean? This corresponds to inspiratory leaks, in which the positive part is greater than the negative part. Probably is one of the things you must remember in the interpretation of volume time waveform. Okay, the second concept would be we have two important waveforms. The volume and flow is the same, so we have two important waveforms. It's pressure and flow. Which one is the most important? And I would like to introduce the concept of independent and dependent variable. What is the independent variable, independent waveform, or independent parameter? Independent variable is the condition met by the ventilator according to set parameters. What does it mean? In pressure modes, the independent variable is the pressure time waveform. Why? Because the ventilator will do everything to meet the set parameters. If you program, if you set an IPAP of 20 centimeters of water, the ventilator will try to reach this 20 centimeters of water. And in volume modes is the flow time waveform. Remember, flow and volume is the same. And what's the dependent variable? The dependent variable is in pressure modes is the flow time waveform, and in volume modes is the pressure time waveform. And what does it mean? It means that the dependent variable contains the most useful information because it labels the patient, or it contains the patient-ventilator interaction. In other words, how this condition, how this independent variable is met. So, in summary, the strategy, the correct strategy for interpreting the ventilator waveform is to detect the dependent variable. It contains around 90% of the useful information. Let's start with the basic concept in semiology of volume modes. In this slide, you can see the normal waveforms in volume mode: flow, pressure, and volume. As I've said before, our dependent variable, we are working with volume, our dependent variable would be the pressure. So our eyes should be directed towards the pressure at the first stage. And what can the pressure do? Pressure can increase or pressure can decrease. And what happens if pressure is increasing? If the pressure is increasing, suggests obstruction of the airway. And if we set the alarms below the airway pressure, the current airway pressure, the ventilator automatically stops the cycle. That is shorter and with less volume than the tidal volume set on the ventilator. In this tracing here, there is a cycle, this one, that is shorter with higher pressure and less volume than the remaining ones. So it seems that in this cycle, the upper pressure alarm is reached. What can we say if the pressure is decreasing? I would like to explain this tracing. This tracing comes from a simulator model. We have flow, the first tracing, pressure. This is effort. What does it mean? At the first part of the sequence, there is no effort. It means that these cycles are controlled cycles. We have increased the effort in two different stages, a moderate effort and a severe effort. And this is volume. Look at the dependent variable. The dependent variable, what happens in the dependent variable? This is the controlled cycles, and as we progressively increase the effort, look at the pressure. The pressure is decreasing. So one important concept is that when the pressure is decreasing, it can be a sign of increased effort. And here at the right side of the slide, you can see three different pressure waveforms. A passive inflation is the same that we can see here. It's a controlled cycle, an assisted breath, and the difference between the assisted breath and the passive inflation. This shadowed area is directly proportional to the work of breathing. This is the so-called Campbell's diagram, and it's very, very known by the intensivist. Applying this rule to our tracing, you can see that the work of breathing here, the three last breaths of the sequence is much higher than in the previous ones. So when pressure is decreasing, you have to rule out the increased effort. But not only this, there is a second situation in which pressure is decreasing. It's leaks. This is a clinical tracing in which in volume mode, you can see here that the flow is exponentially decreasing. Why is this? Because we have selected a decreasing ramp and the volume mode. You can select a flat ramp or a decreasing ramp. In this tracing, we have selected a decreasing ramp. It's not pressure support, it's volume. Okay, when leaks appear, happens two different things. The first one is the pressure decrease, and the second one is that the expiratory flow is missing in leaks because the expiratory flow is not reaching the pneumotach inside the ventilator. So the differential diagnosis of the pressure decrease in volume mode is the effort, increased effort, comprises the increased effort of the patient and the leaks. This is another example of leaks in volume mode. You can see two different kind of tracings, a kind of tracing with a complete inspiratory and expiratory flow waveform in green, and a second type of cycles in which the pressure decrease and the expiratory waveform nearly disappear. This is the typical semiology of leaks in volume mode. But you have to know another situation where expiratory flow is missing. For example, this is an example of the use of active valve. You know that there are 3 different configurations in non-invasive ventilation: double limb, single limb with leaks, and active valve. If you are using an active valve, the expiratory flow is eliminated through the active valve, so does not reach the ventilator. And you can see here that the flow waveform does not contain the expiratory waveform. Okay, these are the basic concepts for interpreting the volume modes. What about pressure modes? These are the normal waveform in pressure modes. Pressure waveform is usually square, and flow waveform is usually exponential, decreasing during inspiratory phase and increasing during the expiratory phase. Let's start with the analysis of the normal waveforms in pressure modes. Let's start identifying our dependent variable. As I said before, pressure modes, the dependent variable containing the majority of information is the flow time waveform. Okay, we can make a sort of anatomy of the normal flow time waveform. The inspiratory cycle starts here with the trigger and the ramp, and we have a peak flow, a maximum flow early in the cycle, a homogeneous decreasing slope until the cycling to expiration is reached, and in the negative phase we have an early negative maximum flow and ascending expiratory slope. So this is the normal waveform. The flow waveform different to this should be considered as abnormal. The first concept would be that the peak flow, the maximum flow, is directly related to effort. Let's analyze this simulation. In this simulation, remember, flow at the top, pressure in the middle, effort, the third channel, and volume, the bottom. So what did we do? We change, in this sequence, we change the effort. From a moderate effort during the first half of the cycle, we shifted to an increased effort. And let's analyze the volume waveform. The flow waveform. Look at the peak flow. Peak flow is much higher in the cycles with high effort. And here there is a clinical tracing, and the clinical tracing contains also 2 types of cycles. These cycles, this one, this one, this one, this one, this one, and this one, more or less, it seems the normal flow waveform. And these 2 or even 3 cycles present several abnormalities. Several abnormalities, why? Because the peak flow is lower than the other ones. These cycles are controlled. Like, look at the distance between the previous cycle and this one. The distance is higher than, for example, this distance, and so on. So the first concept is the controlled cycles always present a lower peak flow than the assisted cycles. In fact, we described this in our framework for ventilator patient ventilator asynchrony during long-term non-invasive ventilation. One of the criteria we described to distinguish assisted and controlled cycles was the peak flow criterion. Peak flow, remember this, peak flow is always lower in the controlled cycles than in the assisted cycles. And the paradigm of lower peak flow is when there is an obstruction. This is the main cause of a peak flow decrease. There's an obstruction. Look at the main changes are found in flow waveform, and the decrease in the peak flow is a sign also of airway obstruction. Let's progress to the next concept, the inspiratory slope. This is really linked to another concept. It's the concept of time constant. Time constant, remember that it's longer in obstructive patients. This is simulating an obstructive patient, and you can see that the slope is less pronounced, for example, if we compare it with restrictive patients. The time constant and the slope are really faster here in the restrictive model than in the obstructive model. This is a summary of the different possibilities we have in the positive slope, the descending slope. Faster in restrictive, slower in obstructive, and almost flat where there are leakage. In fact, we also describe a slope criterion to distinguish between the controlled and assisted cycles. The slope is always lower, or is usually lower in the controlled cycles compared with assisted cycles. Another important concept is that the time constant should be homogeneous and is directly related to the mechanics of the patient, or even to the external factors like leaks. So what does it mean? It means that, for example, this cycles here, this cycle here, this one here, and this one here, the time constant is not homogeneous and should be considered as abnormal. Something is happening here, 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 or here. This is another example. You can see that almost all of the cycles present a descending slope that could be considered as homogeneous, but in this one, we have a double, or as a normal waveform, or we have a double time constant. What happens here? Happens that the patient is starting the effort. This is the thoracic and abdominal belt. Patient starting the effort just in the middle of the cycle, causing this abnormal flow waveform. Summarizing the slope. Abnormal, we can find abnormal flow waveform or abnormal slope in two different situations. When we have changes in impedance, so it means leaks or obstruction, or changes in patient's effort. Let's see this really abnormal tracing. You can find, for example, if I try to find a normal flow waveform, this is from France, the bit flow. Probably this should be considered as normal, this one, and probably this one. What happens, for example, here? The time constant, the peak flow is lower, and the time constant is not homogeneous. So the time constant is almost flat, similar to the pressure waveform. Probably here is a cycle with leaks here, here, here. Here probably is a cycle with an intracycle effort. Here some leaks, and so on. So the summary would be that the abnormal flow waveforms would be caused by these two different situations, changes in impedance or changes in patient's effort. And we finish with the expiratory flow waveform. The expiratory flow waveform, I could say that it's a sort of mirror of the inspiratory flow waveform. The expiratory flow waveform presents an early expiratory peak flow at the beginning of the expiratory phase and an increasing slope that is longer in obstructive patients. In certain situations, the 0 point is not reached, that this is traditionally linked to the concept of expiratory limitation. And the restrictive patients, in the restrictive patients, there is a short time constant with a rapid emptying. In certain situations, we could see also a double time constant in the expiratory waveform. For example, here you have a rapid emptying, a fast emptying at the beginning, and a slower emptying in the second phase of the expiratory waveform. This has been typically linked to the concept of expiratory flow limitation. And the change of trend, this point, has considered to correspond to the choke point in which the airway is collapsed. So when you see this kind of waveforms, this highly suggests expiratory flow limitation. Okay, after these concepts, how can we read ventilator waveforms? We have several kinds of data available. We have compressed data coming from the built-in software, we have detailed data, and we have polygraphy with accessory signals. This is an algorithm I'd like very much because it contains the proceeding you can follow to read ventilator waveforms. Never forget that the reading of the tracing should be linked to the clinical assessment with the transcutaneous CO2, nocturnal oximetry, symptoms, arterial blood gases, and so on. The first step would be the compliance pattern. Compliance pattern that is can be provided by the built-in software. This is an example of the Breas built-in software. This is the total amount of hours of the patient is using the ventilator, and this is the fragmentation of the hours the patient is using the ventilator. For example, this is a patient that uses the ventilator here in the afternoon and during the night, and some nights. For example, this one, this is you can see a fragmented using of the ventilator. This is the first step. The second step would be the assessment of leaks. And this is different if you are working with built-in software or you are working with polygraphy. If you are working with built-in software, the manufacturers are usually very kind and provide us a specific channel for knowing the leakage. This is the channel for leakage. If you see that this channel, the value is increasing, okay, it's easy to say that you can interpret that there's a leakage in the tracing. In this case, leakage is represented both with intentional and non-intentional leakage. And I usually look at the beginning of the tracing, at the beginning of the night, to have a sort of reference to read the tracing during all the night. For example, in this tracing, during the first part of the night, I usually take the reference these values. If I take the reference here, you can see that this period present a very high leak value. So it's different when we work with polygraphy. If we work with polygraphy, the signal you are monitoring contains the flow directed to the patient, the tidal volume or flow from the patient, and the leaks. So in this tracing, we can distinguish two different semiologies. This could be considered the normal semiology with exponential decreasing in the inspiration, exponential increasing, during expiration. And in this part of the tracing, the normal semiology is losing. For example, here the baseline is increased and the flow and pressure could be considered as very similar. This is the typical semiology of leaks with polygraphy and consists of an increase in baseline and flattening of the inspiratory. What happened? Do you see my presentation?
No. Would you mind sharing your screen again for us, Manel, please?
Wait a moment. Now?
Yes.
Okay.
Back.
Sorry for the inconvenience. Okay. Leaks can also be isolated. For example, in this example, the cycle leveled with number 1 can be considered. Look at the pressure and look at the flow, really very similar. The time constant is really flat, so we can say that there is isolated leaks in the cycle labeled with number 1. Second step would be the periodic flow decrease. You know, this is a pressure mode. Our dependent variable is the flow, and you can see cycling decreasing in the flow waveform here and here. For those, for correct interpretation, for a correct lecture reading of the periodic decrease of flow waveform, we need to know what's doing the patient. And in summary, the patient can do two different things against the obstruction: fighting or not fighting against the obstruction. We need for an assessment, an adequate assessment of the periodic decrease of the flow, we need to know what's doing the patient by means of the measuring the inspiratory effort of the patient by the plethysmography, inductance plethysmography, bells, or electromyogram. Here we have the signal from the thoracic and abdominal bells. And as I've said before, the question is whether or not the patient is fighting against the obstruction. For example, there is a decrease here in the flow waveform, and the patient is clearly fighting against the obstruction. The number of breaths during this episode is higher than the number of breaths during the periodic flow decrease. Clearly, the patient is fighting against the obstruction. And this one, the patient during this small obstruction is clearly not fighting against the obstruction. You can see a flat line here in the thoracic in the abdominal belt. And here, the patient is ventilated passively during the decrease of during the flow decrease. For example, this, or this cycle. So the question is, here the patient is fighting against the obstruction, here it's not fighting, the glottis is closed, and here the patient is ventilated passively. The last part of my speech is dedicated to the ventilator patient asynchrony, primary asynchronies. We described 2 years ago, 3 years ago, how to proceed with patient ventilator asynchrony. And if you can see, this is the one of the flow charts of contained in this article. Step 1 is rule out leaks and rule out obstruction. And once the leak and obstruction have been ruled out, we can say that this patient, the following step would be to identify asynchrony. We split the asynchronies in 2 different groups, rate asynchrony and intracycle asynchrony. Rate asynchrony can be identified by visual inspection, and rate asynchrony you can find more cycles than expected or less cycles than expected. If we identify more cycles than expected, in other words, the ventilator rate is higher than the patient rate, too many cycles, we have 3 different possibilities: double triggering, auto triggering, or uncoupling. Double triggering is a situation, is an asynchrony in which one single effort of the patient corresponds to 2 different cycles, both in flow waveform and in pressure waveform. And double triggering have a special features as we describe it in the paper. If you look the dependent variable, this one, the flow, the first peak of the double triggering is always higher than the second peak, and the first valley between both cycles is usually less negative than the second one. And this is the typical morphology of the double triggering. And as I've said before, it's important not only to read, but also to understand what's happening. And double triggering should be considered a demand asynchrony. A demand asynchrony because with the first cycle does not match with the inspiratory demand of the patient. What can we do? If it's an increased demand, we should increase the support or increase the inspiratory time, especially if we are working in pressure control modes. Okay. The second possibility is auto triggering. Auto triggering is a cycle or cycles, assisted cycles, but not demanded by the patient. For example, if we look at the simulation, this cycle corresponds to this effort to the cycle, but there is an effort in the middle here and here that not correspond to the effort of the patient and should not be considered as a control cycle because the distance between the previous cycle is lower than this one, for example. This is an auto-triggering. This is a clinical example of auto-triggering. here. This is an auto-triggering here, here, and here. What can we do in presence of auto-triggering? Auto-triggering is asynchrony typically linked to leaks. So the first step to correct auto-triggering should be discard, rule out leaks. If there are no leaks, we can modify the trigger level or even change the ventilator. Uncoupling, I do not have so much more time. Let's continue with the opposite situation in which the ventilator rate is less than the patient rate. In other words, we have too few cycles, or we have missing cycles in the tracing. There's a single situation explaining this, that is the ineffective effort. The ineffective effort, if we look at the simulation, you can see that this effort does not correspond with a ventilator cycle, but in the pressure, in the flow waveform, you can see this small wavelets here, here, and here. This correspond to the effort of the patient or simulator, but without a cycle in the ventilator. If we find ineffective efforts in our tracings, coming back to pathophysiology, what can we do? There are different situations that could explain the presence of ineffective efforts. The first one is the air trapping or auto PIP. This is typically a situation in which the ineffective effort can be explained with when we explain it by air trapping. Why? Because if you see the zero line, clearly all the efforts are below the zero line. This one, and this one. So the first condition associated with ineffective effort would be the auto PIP, air trapping, and so on. And it's an asynchrony that is really characteristic of the in the COPD patients. Second one is to rule out leaks, and third one would be an inappropriate selection of the trigger. But it's important to investigate which of these three different conditions would be associated with ineffective efforts in the single patient. Let's continue with the flow asynchrony. Flow asynchrony is produced when the effort of the patient is not correctly matched by the ventilator. For example, under resistance, the patient has a big effort not matched by the ventilator. And in the simulation, you can see that in the first half of the screen, the effort is moderate, and the second half, the effort is really greater. And if we see this time in the pressure waveform, we can see that the pressure waveform is really smoothed, and with this expiratory, with this peak at the late inspiratory phase. This has been described in the literature as lead up, late inspiratory rise in airway pressure, and it's typically associated to under assistance. If it's a demand asynchrony, what can we do? Increase the pressure report or shorten, this is not increasing, it's shorten the rise time. And I'm finishing with the two last asynchronies. Time asynchronies, long cycle. Long cycle is produced, or delayed cycle is produced when the cycle in the ventilator is longer than the patient effort. You can see here, remember when I was speaking about the difference in controlled and assisted cycles. if you can see here, this short effort corresponds to this double time constant in inspiratory phase of this cycle. The first part belonging to the effort is the time constant is faster than the second one, that is slower. So in summary, the combination of the two time constant during inspiratory phase seems suggestive of delayed cycling. Is a combination of an assisted cycle, first part, and a controlled cycle, the second part. What can we do? Modify the cycling of Criterion or shorten the TI max, especially when leaks are suspected. And short cycle, just the opposite, the effort of the patient, in this case the simulator, is longer than the ventilator cycle. And the typical increasing exponential expiratory waveform is losing. And in the expiratory waveform, you can see this small notch at the beginning of the expiratory phase, suggesting that the effort of the patient is really prolonged in these 3 cycles, or, for example, here in a clinical tracing. So what can we do to modify the cycling of Criterion at lower a percentage of peak flow or even increase pressure support? So, in summary, how to read and understand ventilator waveforms. First of all, identify mode. This is the first step. Second step would be identify dependent variable that will provide you 90% of the information, and the interpretation or the adequate interpretation of patient-ventilator interaction is a combination of the understanding these waveforms and a systematic procedure in reading them. Thank you very much for your attention, and to conclude, I would like to introduce the next speaker, Michelle Chadwin, that next month will talk about how to use stepped insufflation. Thank you very much for your attention.
Thank you very much, Dr. Luján. I would like to invite the audience again to post their questions in the chat function, which you can find in the upper right corner of your screen. Don't worry if you don't see them published, we see them here at our end, so your questions will be lifted and answered by Dr. Luján. And we do have a number of questions that came in throughout your presentation. The first one is a question. In the last part, you talk about asynchronies. How much asynchrony can we allow for? When do they need to be corrected? Always, question mark.
Yes, this is a good question. The answer is really difficult. What we do? What can we do? First one, the first rule would be not to worsen, because if you try to correct all the asynchronies in an overall night, you are worsening the patient-ventilator interactions. So my usual procedure is, if there is a more prevalent asynchrony, for example, if I have a tracing with auto-triggering, this tracing of this asynchrony should be corrected, modifying the trigger, ruling out leaks, and so on. If there is a ineffective force during all the tracing, should be corrected. Discard leaks, change the inspiratory maximum inspiratory time, try to shorten inspiratory time, try to enlarge expiratory time, and so on. We did a study about prevalence of asynchronous in polygraphies. It's pending publication, in which we can describe really a high number of asynchronous. I remember the exact number was more than 100 asynchronous per hour of register in a selected group of polygraphies. And this is really a high number of asynchronous. If you try to correct all these asynchronous, you would be crazy. You become crazy, really. So the first step would be, is the patient comfortable? Yes or not? Okay, this is the first one. The second one, is an asynchrony more prevalent during the night? Yes or not? If there is a single asynchrony more prevalent, try to know the pathophysiology, and then if you know the pathophysiology, try to correct it. And a third one, is this asynchrony linked to the saturation in the nocturnal oximetry? Yes or not? If there is an association between the asynchronous and the oximetry, try to correct.
Okay, thank you very much. Another question which came in is, you spoke about the expiratory flow waveform. When we use NIV with a passive circuit, is the expiratory flow waveform accurate on most devices?
It depends. Yes, it's a very, very good question. If you work with built-in software, the vast majority of manufacturers provide a corrected flow waveform. This is related to the 0 point. In this situation, despite the expiratory flow waveform is estimated, I rely on this on the semiology of this waveform. If you work with polygraphy in a single limb with leak, the semiology can be more difficult. The interpretation of the semiology can be more difficult because the expiratory part of the cycle is shifted upwards and is reduced compared to the inspiratory part of the waveform. So, in summary, if you work with a corrected flow waveform, you can rely on the expiratory flow waveform semiology. If you are working with raw data, with polygraphy, that could be more difficult. The interpretation of the expiratory waveform could be more difficult.
Okay, thank you. Another one which came in has to do around the leakage, and the question is, what is the impact on leak on modes like AVAPs or target volume?
Okay, in AVAPs, I don't understand very well the question. The question is related? Is the question related to intentional, non-intentional leak, or both? Can you repeat the question?
When it comes to leak, how much does it affect modes like AVAPs or target volume? I think it's about unintentional leaks, honestly.
Yeah, okay. Obviously, leaks is a function of the pressure. If the pressure is increased, intentional leak is increased. If you're increasing the pressure, you have more the likelihood of increased non-intentional leaks also increasing.
Okay, yeah. We have two more questions, but please, if you have more here, people that are still on the call, feel free to put them in the chat. There is one of the attendees who says, my patient is on an ST mode and runs large parts of the night on T breaths. without spontaneous breaths. Is that okay, or is it a patient ventilator asynchrony?
I will answer with a sentence of my good friend Claudio Rabec. This is the symphony of the ventilation. When the patient is on T mode during the entire night, after obviously after ruling out leaks, this is a well ventilated patient, in my opinion. This is not should be considered as asynchrony.
Okay, so we can accept that as long as the outcome is fine.
Yes, absolutely, yeah. Absolutely. Most of my patients, or the most stable patients at the hospital, are on T mode during all the night.
Okay, great. And then the last question, I kept this one for last as it has Breas in the question. There is one of the attendees saying, I know that Breas' newest devices allow for the addition of effort belts. Do you think these are useful, and if so, when?
Absolutely, yes. For second and third step of the procedure of reading, the bells are useful. For example, to know if the patient is fighting or not against an obstruction. Without the belts, it's impossible to know if the patient is fighting or not against the obstruction. And in the complex asynchronies, the information from the bells is also useful for complete understanding of the tracing.
Good. Thank you very much, Dr. Luján. I think this was the last question here on our list. Thank you, everybody. Thank you, first of all, Dr. Luján, for a very entertaining presentation. I think all of us learned a lot on how to read ventilator waveforms. I thank all the attendees for you to be on this webinar today and take the time to be here.